Hello and welcome to Pulmonology Read Aloud. Today's video is about hypersensitivity pneumonitis, the 2024 update. In case you're new to my channel, please do subscribe, like, and share this channel for everything in pulmonology. So today I will be reading aloud two main articles. The first article here is a review article on hypersensitivity pneumonitis, the challenges of a complex disease. So this article deals with the etiopathogenesis, the diagnosis, course of action, along with it. And this was published in the Canadian Respiratory Journal in 2024. We will also be briefly mentioning the only practice guideline that is there right now, which is on the diagnosis of hypersensitivity pneumonitis in adult, and ATS JRS ALAT clinical practice guideline, which was published in American Journal of Respiratory Critical Care Medicine in 2020. So let's get started with our video with the definition of hypersensitivity pneumonitis. Now, we all know that hypersensitivity pneumonitis is an inflammatory disease. It is an interstitial lung disease and a very complex interstitial lung disease, which is mediated by both humoral as well as cellular mechanisms. And it is caused by this immune mediated inflammation in the lungs. Now, there are usually an antigen exposure following which the innate immune system processes that antigen and an inflammatory response is elicited. So, it is driven by a chronic inhalation of certain trigger antigens. And this inflammatory response is predominantly mediated by the T helper cells and certain antigen specific immunoglobulin G antibodies. And when that happens, there is an accumulation of lymphocytes and there is formation of granulomas. So it happens in susceptible and sensitized individuals. It's reported more in adults than in children. And while the pathogenesis of why fibrosis occurs in this disease is not understood, it's believed that because of an abnormal repair of this inflammation in the lungs, there is an alveolar epithelial cell injury leading to fibroblasts and leading to accumulation of extracellular matrix and thus the fibrosis. So, complex interstitial immune mediated inflammation, chronic inhalation of wide variety of antigens in susceptible, sensitized, mostly adults, and it is commonly associated with an occupational setting, which is a very important cause of hypersensitivity pneumonitis in lot many patients. Now, there are a variety of nomenclatures that exist, and earlier the same entity was also called as extrinsic allergic alveolitis, also called as hay fever, farmer's lung, bird fancier's lung, hot sauna bath lung, and so on. So, there are various names which are given to the particular antigen or etiology, but they all point to hypersensitivity pneumonitis. What is the basis of diagnosis of this disease? The review article clearly mentions that based on the so far existing guidelines and all the expert consensus, either hypersensitivity pneumonitis can be diagnosed just on a clinician's judgment based on the various clinical findings, the investigations, the radiology, the serology, or in inconclusive patients or where the scenario is more complex, a multidisciplinary team discussion, an MDT, can be done. And then, based on the history, the imaging, the BAL pattern, if done, and the immunological and histopathological findings, one can come to the diagnosis of this disease. What is the epidemiology of this disease? This is really important because, again, there's a lot of ambiguity in this. The incidence reported worldwide, according to this review paper, is 0.13 to 1.94 cases per lakh population, with the prevalence of 0.4 to 2.7 cases per lakh. However, in India, the most common ILD reported as per the ILD India registry, which was published in 2017, was hypersensitivity pneumonitis in 47%. But there were a lot of discussion around it, and some people believe that it was arising because of a bias and arising because of non specific diagnosis based on just the clinician's impression of the ILD. However, that was a huge number to be quoted. There was another registry which was published again by a very premier institute of India, PGI Chandigarh, who actually reported sarcoidosis to be the most common ILD in India. But having said that, despite the ambiguity involved, we know that it is a very common entity and is not as rare in India as was thought before. Also, it's important to recognize that occupational hypersensitivity pneumonitis occurs in every fifth patient of hypersensitivity pneumonitis. So, again, people with high risk occupations must be screened for this. And there is a significant variation in the prevalence from a country to country, from a geographical area to the other, based on the climate, season, what are the type of antigens one is exposed to, what is the level of industrialization, what are the agricultural techniques, and other environmental conditions in a patient. There's also an entity described in the AJRCCM paper, which is HP of undetermined cause, which involves patients in whom a culprit exposure has not been identified, but the features are of HP. It's also called as cryptogenic HP, was part of the ATS JRS ALAT practice guideline in 2020. We do not use the term acute, subacute, and chronic now. They have been taken off. The main reason was that it does not make a significant difference in approach to management, so these terms were taken off. Now let's come to certain antigens and the exposure. Now, broadly, we could divide the antigenic exposure in HP into workplace, home, or recreational exposures, or the other way we can divide it is into organic or inorganic exposure. So the exposure can occur at the work, at the home, or because of certain recreation that the patient is doing. So if you look closely at this screenshot taken from the Canadian Respiratory Journal article, amongst agriculturists, farmers are exposed to a lot of possible antigens, which include decaying vegetation, decaying grass, soil, plant, fruit surfaces, honeybee environment, moldy hay, straw, plant material, and recently even hydroponic farming, which involves mushroom growing, which involves growing lettuce and other leafy vegetables in a controlled environment. They have also been associated, and most commonly, when you're talking about agricultural exposure, the antigen is the fungi. So, Saccharomycetes or Absidia or thermophilic actinomycetes, streptomyces. So these and aspergillus, a very, very strong exposure to aspergillus, these are most common culprits. If you look at the poultry, then bird feeders, so hen workers, pigeon breeders, those who handle duck and geese and feathers, especially pigeon. So in India, again, pigeon is one very commonly recognized trigger. So pigeon, parrots, chicken, turkey, so all of these, they can be exposed, and the antigen here is the bird dropping or feather. In fact, I recently had a patient who had parrots in her house who would sleep in her bedroom. So the cage would hang in the bedroom at night in winters because they felt that they might get cold, and they were all over the place in the house. And this patient developed a sudden, gradually progressive chest tightness and breathlessness and new onset asthma like symptoms, which were actually attributed to the parrots. Also, food industry. So here, cheese producers, bakers, soy sauce brewers, wine growers. Again, because of penicillium and other fungi like aspergillus, there could be a risk of HP. And construction workers, people who are involved in varnishing industry, in woodwork, wood trimmer, glue, polyurethane foam, paint, plastic, because of various chemicals like isocyanates, and also because of certain fungi like mucor, they may be exposed. About 30% of all HP cases, however, that we see, especially in our continent, are attributed to bird exposures like pigeons, parrots, ducks, goose, and others, and bird droppings, causing what we call as bird fancier's disease. And if we talk about overall occupation, farming is the second most common occupation because there's so much of vast spectrum of how a person can get exposed to workplace because of the vegetation, because of the organic waste, and because of common sources like bacterial and fungal antigens. Let's look at this list of miscellaneous, which includes wind instrument players like trombone, trumpet, and flute, because there could be atypical mycobacteria or fusarium or thermoactinomyces or aspergillus. There also air conditioning, humidifier, swamp coolers, which can result in contaminated water, again contaminated with these fungi. So again, coolers and air conditioners, dental technicians, and one thing that I would want you to note here is CPAP machine and nebulizers, because of again the contaminated water which is used in humidification, contaminated water jets and spray, pseudomonas, which is a very common antigen when we look at um, concentrators with humidification and others. So these, and along with these, even other agents such as viral infections that can trigger or exacerbate an hypersensitivity to an environmental antigen, because when you are infected with virus, again it increases the antigen presenting capacity of the alveolar macrophages. The clearance of the antigen is poor, so cytokine release is much more. There are also reports that tobacco smoking has an impact on our immune reactivity to the antigens and towards the fibrotic process. So, there is a need to evaluate all of these occupational and environmental triggers when we're dealing with a patient with HP. If we have to make a list of the most common organisms that cause HP, then this is the list, and Aspergillus and Penicillium species are high up on our list. So, what does it present as? So, as mentioned, the presentation of a patient is very heterogeneous or non-specific. And we don't use the presentation as acute, subacute, chronic anymore. We divide HP into fibrotic and non-fibrotic because that is where the outcome depends on. But a patient can come with very non-specific complaints, such as in the acute phase, just come with a cough, dyspnea, and generalized fatigue. If a patient has a very high grade exposure to the antigens, then immediately after exposure, within 6 to 8 hours, he may have a very high symptom score. So it varies from patient to patient. We can also say that there are various phenotypes in which this may present. Most commonly, an intermittent flu like syndrome to an insidious onset. Symptoms may be days or weeks or months. Sometimes, when people have occupational exposure, they usually start showing the symptoms at the end of the working day, and they resolve after 24 to 48 hours of discontinuation of their exposure. So, they may experience symptoms during the working days and they may get better during the weekends. This is a table showing the clinical presentation of HP. If we talk about non-fibrotic HP, patients can have a high-level intermittent exposure of the identifiable antigen, which can start hours or days. As I said, generalized complaints, flu-like symptoms. You may see a bibasal bibasilar crackles and mild inspiratory squeaks in these patients. Symptoms usually resolve within 12 hours to stopping the exposure, and if it's a repeated exposure, then they may actually not recover. If we talk about fibrotic HP, there's a low level continuous exposure. Months after exposure, also patient has symptoms. It's insidious. It may have no acute episodes also. Bilateral crackles with signs of cyanosis, cor pulmonale, and clubbing if it's a chronic type 1 respiratory failure, and end stage fibrotic disease. So that one has more poorer prognosis. This is how one can see both the guidelines, the chest guideline and the ATS JRS ALAT guideline face to face. So initially, the guidelines used to mention that we have to take a thorough clinical history of exposure, occupational history, how a patient improves after avoiding an antigen, and to support diagnosis, you could do serum serology and specific IgG and IgA testing. The ATS guideline mentions that yes, thorough history is important, but you should also include questionnaires and a serum specific IgG testing may be done. As far as HRCT role, both agree that HRCT must be integrated and is essential to do. The CHESS guideline did not routinely recommend BAL, and the ATS guideline did recommend BAL for lymphocyte count, especially non-fibrotic HP, and it suggested for fibrotic HP because, according to them, when you do a transbronchial biopsy, it increases the diagnostic yield. So lung biopsy is only indicated when clinical, lab, HRCT, and other things do not support your diagnosis. There is no recommendation regarding preferred methods in the CHEST guideline, but the ATS guideline of 2020 did mention transbronchial biopsy for non-fibrotic HP, cryobiopsy for fibrotic HP, and surgical lung biopsy when alternatives were not available. Talking about an MDT, the CHESS guideline mentions that if you need to decide whether you should do a lung biopsy and take a decision, you could do MDT, and ATS guidelines also supports that. So basically, if you look at both the guidelines and overall review, diagnosing a patient with HP is more like joining a puzzle. So, no one single entity can help you clinch the diagnosis. You need the clinical features, you need the lung function, the exposure history, the HRCT, and if you can do a BAL, you will have lymphocytosis to support. So, everything has an important significance, and that's why there is no gold standard one test, but yes, all of these are important. What are the main tips to assess a patient with HP whenever you come across any patient with ILD? HP should be kept as a potential diagnosis. So the history has to cater to that. And if you have a suggestive imaging pattern, then you have to take note of it. If you have a strong exposure history and patient presents with frank UIP, then also, or if you have an occupational history, then also you would consider the diagnosis as HP. And so, occupational history should be a mandatory diagnostic tool when we're talking about the diagnostic algorithm of a newly diagnosed patient with ILD. This is a very good chart which was in the ERS review that I mentioned in 2022, algorithm for diagnosing HP. So patient with newly detected ILD on chest imaging, you ask for exposure, you see the HRCT scan. You could do a BAL with lymphocyte cellular analysis with or without biopsy. If you can identify the exposure and typical HP pattern and BAL lymphocytosis, you could either go for a multidisciplinary discussion, there's a high confidence and you diagnose HP, or if you have all other combinations of exposure, CT, TBLB, BAL, but the diagnosis is unclear, then you could take a multidisciplinary discussion. If nothing is very clear, you ask the patient to undergo a surgical lung biopsy or a transbronchial lung cryobiopsy, and based on the discussion, diagnose HP according to the ERS review of 2022. This is, in contrast, the diagnostic algorithm in a patient based on the chest guidelines where there's no indication of a lung biopsy. So, if you know that there is an identifiable antigen exposure, then you and the typical HRCT pattern, which we'll be discussing, you may or may not have the BAL. You could do an MDD and diagnose HP. If you have an indeterminate exposure, you don't have a very good exposure, but the pattern is typical, you could do a BAL here to support your diagnosis and start him on treatment. And if there is no identification of an antigen exposure, but the CT looks like it could be HP, you must try and again prove the diagnosis by adding another modality like BAL or do the MDD and do a high confidence diagnosis. And lung biopsy can be done with the risk benefit ratio. if the features are not highly suggestive, but you are clinically suspecting. These are the factors that are associated with mortality in patients with HP. And how I see this is that whenever you diagnose a patient with HP, they're bound to ask you, doctor, is it very serious? What can be serious or what can have more mortality is patients with older age. There are studies that show people above 65 have higher mortality compared to less than that. Male sex, genetic predisposition. If you're not able to find out the antigen, and the duration to the exposure to the antigen has been high. Smokers can have a poor lung function and so more mortality. People with low lung volumes, low DLCO, declining volumes. People with the lower bowel lymphocytosis, those with fibrotic HP, where the extent of fibrosis is more, or we see a UIP pattern or a fibrotic NSIP pattern on histology, is the ones that will have a poorer prognosis. This is about the HRCT, which is a very, very important and indispensable tool. So here you can see that they pictorially shown in the ERS review article of how once you have an inhaled small organic particle, there is a reaction that occurs to it. So firstly, there's bronchocentric inflammation. So the inhaled antigen causes a bronchocentric inflammation, which you will see in the form of centrilobular ground glass nodules. Then your patient may have narrowing of the small airway. So he may have small airway disease, which is seen in the form of air trapping, and the patient may have an interstitial inflammation, which will be seen in the form of ground glassing, reticular shadows, and sometimes it may proceed to frank fibrosis. So you may see a mosaic attenuation pattern, you may see a 3 density pattern in those lobular areas where ground glassing is intermixed with normal appearance. So a patchwork of lobules with differing density will be mosaic, and a patchwork of lobules with normal ground glass and those lobules with decreased density and decreased vessel size because of air trapping will be called the 3 density pattern, which is one of the most specific signs for HP on HRCT. And to be able to see this sign, however, we have to be suspicious of our diagnosis and ask the radiologist to do an expiratory scan. And then we can see 3 different patterns, 3 density sign. This is a very beautiful chart, or which basically summarizes how one can differentiate between HP and IPF. If you are seeing the UIP pattern, I try to zoom it as much as possible for us to see clearly, but I apologize because this is the way it is there in the article. I'll try to read through it. So if you look at IPF, it's usually male predominant with older age and smokers or former smokers. But HP, you do not have any significant predominance of the sex or the age. Obviously, smokers, however, do have more chances. Also, the family history of fibrosis or predisposing factors. Patients may have dyspnea and cough, and there will usually be no identifiable antigen, whether we are talking about IPF or HP in both the scenarios. Both the scenarios will have restrictive ventilatory defect. Sometimes you may have a mixed pattern, like if it's a smoker or there's small airway disease involvement. And if you look at BAL, then you may get BAL which is suspicious of HP if it has lymphocytosis. And if you look at IPF, you may have a negative or a weakly positive autoimmune serology with BAL neutrophilia and absence of lymphocytosis. Typically, IPF is usually progressive and HP can become stable. If you look at the HRCT patterns, we know cradiocaudal. So the bases have more changes, including the costophrenic angles, subpleural predominant reticular opacities, minimal ground glass, very little ground glass, more honeycombing, and no small airway disease. But when you look at HP, then it could be a variable. It could be craniocaudal, but usually mid and upper lung is more prominent, and also you might see reticular pattern and traction bronchiectasis, especially in fibrotic, but you will see signs of air trapping and small airway disease, which discriminates it from the IPF pattern. Coming to the HRCT pattern, which we just discussed. So again, UIP or honeycombing or probable UIP with IPF, and with HP, you can have a compatible pattern with HP, which includes central lobular nodules, hypoattenuating. Expiratory imaging will show air trapping, and you can have the pattern which is atypical of a frank UIP also. So, with that, these are the main factors that distinguish a IPF as well as HP on a HRCT. Coming to few other tests, the first one is serum specific IgG. So serum specific IgGs have been used in a lot of panels to find the offending antigen as a diagnostic tool. It has a sensitivity of 83%, a specificity of 68%, and there are studies that show that if you have an elevated serum IgG level, you will have nearly 10-fold high risk or likelihood of an HP diagnosis. However, they are just markers of exposure. They have to be seen in context with the clinical findings and all the other tests that we have done. There is also an entity called antigen inhalation challenge test, which is mentioned in the review, but it is not recommended by any of the guidelines. It basically means you will nebulize the patient with suspected antigen and then see the lab, the radiology, the lung function within 8 to 12 hours after provocation. It's like a provocation test, very good sensitivity, specificity, however, not recommended because of obvious risks. BAL or bronchoalveolar lavage, we've been talking about this all through. What are the typical findings on bronchoalveolar lavage? Firstly, the CD4 to CDH ratio will be low, with values ranging between only 0.5 to 1.5. Alveolar lymphocytes are much more. So the lymphocyte count of more than 30% in BAL in a patient of ILD can increase the diagnostic confidence for HP to a highly probable HP, and then you don't need a lung biopsy. If you are dealing with a fibrotic HP, you may not have the typical BAL lymphocytosis, so that doesn't exclude it. Absence of lymphocytosis in a non-fibrotic pattern also rules out HP because you would expect lymphocytosis in non-fibrotic types. And it not only rules out infections, it also suggests the prognosis because if you have more fibrosis or less fibrosis, that will be a predictor of response. Chest imaging, we've broadly covered it, but just to summarize, two images should be acquired: deep inspiratory and end expiratory images. That's very, very important to get our diagnosis. And you can see ground glass opacities and mosaic attenuation. You can see parenchymal lesions, nodules, interstitial central lobular nodules, ill defined with air trapping. And as I said, almost pathognomonic sign is the three density sign, previously also known as the head cheese sign. So three densities: the normal density, ground glass attenuation, and decreased density and decreased vessel size due to air trapping. So you see three different densities. That is almost pathognomonic, but you will get it only on an expiratory scan. These are the other imaging patterns, again taken from the review article. This is the first section, the axial section of HRCT, showing the ill-defined central lobular nodules, and you can see these black areas of air trapping, which suggests that there is small airway involvement. The second one, you can see some ground glass opacities and mosaic attenuation. So ground glass alternating with air trapping. So mosaic is ground glass and air trapping. If they two alternate, then it's mosaic. It suggests interstitial infiltration. The third one, you can see three densities. You can see a black, complete black. You can see a grayish area and one with decreased density. So the three density sign: normal, which is your white, this normal, the white astral, this one is normal, Then you can see the ground glass, which is here, and you can see the air trapping, decreased density, which are these black pockets, and the fibrotic HP, which is ground glass with traction bronchiectasis, honeycombing, and fibrotic pattern. And when you're talking about fibrotic pattern, obviously there is a coexistence of all these other patterns sometimes, and then also associated with fibrosis. Lung functions, very important part, mandatory assessment, because again, they're very helpful in following up and predicting the outcome and severity. We all know we expect restriction, which will be coming as reduced FVC, reduced DLCO. And if these two parameters are reduced and they continue to reduce, then you can also have a diagnosis of progressive pulmonary fibrosis. So PPF more than 10% decrease in FVC, or 5 to 9% decrease in FVC, or more than 15% decrease in DLCO, and progression of CT scan over 6 to 12 months is what we define PPF as. We'll do it in the next video, and you may get air trapping. 6-minute walk test, a good test to do in clinic to follow up and prognostic. There is no fixed number, but it is used to follow up the same patient. Lung biopsy, as I said, not all cases, only inconclusive cases once you've done the MDT. If you are doing, you can do transbronchial lung cryo, or surgical. Not a very high diagnostic yield, but the ATS guidelines mention that in non-fibrotic HP, you could do a transbronchial biopsy, preferably over a surgical lung biopsy. But surgical lung biopsy is the gold standard for tissue sampling with a yield of 96% but more morbidity. Coming to the treatment, again, a very, very ambiguous part. We all know that avoiding the antigen is the key to resolving the disease, but there is no unanimous agreement on the therapeutic approach. In fact, I also read through several other articles to find if there were specific treatment cutoffs and information given, but all of them just mention it in a paragraph and end it, because it's still not unanimous. So, antigen avoidance and steroids or immunosuppressants are the therapy in HP. If we talk about antifibrotics, when you have a progressive pulmonary fibrosis phenotype of HP, you can use them. And another option is obviously the lung transplant. So with non-fibrotic HP, we would start with steroids as the drug of choice, prednisolone 0.5 to 1 mg per kg per day for the initial 1 or 2 weeks, and then gradually taper them until a maintenance dose of 10 mg a day once patient is better. And how will we know the patient is better? We need radiological, functional, clinical improvement. And if the patient does not have the exposure, then steroids can be tapered off after several months. Again, a very big question. How many months? Just mention of several months. It could be 6 months, it could be 12 months based on patient to patient. In fibrotic HP, treatment recommendations are a bit more equivocal. The initial dose of corticosteroid, instead of for the first 2 weeks, should be maintained for 4 to 8 weeks. So give it for a month or two, then start tapering to the lowest dose. Again, clinical imaging and functional data will determine the duration. And because there's an inflammatory background of the disease and we don't know the inciting antigen, these patients may require immunosuppression earlier to prevent steroid side effects, and then they may require immunosuppression for extended periods of time. The prolonged use of steroids, because that is one problem when you're having a progressive disease or frequent relapses. In such a scenario, you would want to early transition to steroid sparing agents, which could be, and the studies have shown two main agents, mycophenolate and azathioprine. Again, there is no unanimous decision on which one. They all ask for more randomized studies to see the effectiveness, but majority studies have concluded that the sooner you switch to these, especially in deteriorating patients, that would be better. They have fewer adverse effects. You can give them either as monotherapy or combine them with low dose steroids. And in the case of fibrotic HP compared to steroids, it's seen that azathioprine or MMF had similar mortality risk, but improvement in lung function at the end of 1 year and lesser side effects. So, initially, probably give them with steroids. Once the effect comes, then steroids can be tapered off. So there's a lot of confusion regarding the timing of antifibrotic therapy, which agent to be preferred. But however, we know nintedanib so far is the only approved one for use in fibrotic HP. Pirfenidone had few studies that had to be stopped early on because of recruitment issues. So we still don't know. It may have promising results in future. And whether we should give antifibrotics as add-on to immunosuppression or not, that's again an issue. So if the disease is progressive, we would want to continue immunosuppression and add on antifibrotics. Prevention, very important. If you can prevent the inciting agent, you can prevent the disease. Sometimes you may need to keep the environment very sterile, disinfected, and give the patient personal protective equipment when he's especially in an occupational setting. With that, I close this video. The next video shall be a related video, and I have these two main articles in my mind. The first one is the emerging role of mycophenolate in interstitial lung disease, which is a review, a latest review. And the second one is about progressive pulmonary fibrosis consensus statement, again published recently in 2023. And a lot of our own Indian senior faculty as authors here. So let me know which of these videos would you like to have first. And do keep subscribing, sharing, and liking this channel. And please write your comments in the comment section below. Thank you, happy reading, and have a nice day.